ECG changes based on potassium levels. Hyperkalemia, a condition characterized by elevated potassium levels in the blood, typically greater than 5.5 millimoles per liter. It can lead to life-threatening cardiac arrhythmias. Mild hyperkalemia, 5.5 to 6.0 millimoles per liter. Peak T waves, narrow and tall. Moderate hyperkalemia, 6.1 to 6.9 millimoles per liter. Prolonged PR interval. Flattening or loss of P waves. Widened QRS complex. Severe hyperkalemia, greater than 7.0 millimoles per liter. Sine wave pattern, merging of QRS and T waves. Ventricular fibrillation or asystole, cardiac arrest.
First off, the ST segment on the ECG disappears, kind of like it's playing hide and seek. Then, the T waves get all tall, narrow, and peaked, like little mountain peaks popping up on the screen. The QRS complex, which represents the electrical activity of your heart's ventricles, gets wider, almost like it's stretching out to take up more space. And the P waves, which show the activity of your heart's atria, get wider and flatter, like they're spreading out to make room for the chaos. But wait, it gets even wilder. When your potassium levels hit 7.5 milliequivalents per liter or higher, your heart might just decide to take a little break, with sinus arrest and the P waves disappearing altogether. It's like your heart saying, okay, I need a timeout. And in really extreme cases, when your potassium levels reach the stratosphere, like between 10 and 12 milliequivalents per liter, the QRS complex and the T wave can merge together, causing total chaos in the form of ventricular fibrillation or asystole.
An older adult patient with a history of type 2 diabetes, hypertension, and congestive heart failure presents to the clinic for a follow-up after a new medication was started the previous week. The patient reports severe fatigue, muscle weakness, tingling of the extremities, and heart palpitations. The patient's vital signs include BP 150/94 mmHg, pulse 100 beats/min, temperature 98.6 degrees Fahrenheit 37 degrees Celsius, RR 12 breaths/min. An electrocardiogram is completed. Which medication was most likely recently started? Chlorthalidone, prazosin, minipress, spironolactone, aldactone, furosemide, Lasix. Rationale. Recent use of potassium-sparing diuretics, spironolactone, can cause hyperkalemia. Identified on ECG by tall T waves, wide QRS complexes, and absent P waves. Chlorthalidone. Chlorthalidone is a thiazide diuretic. It enhances the excretion of potassium, magnesium, and sodium and can cause hypokalemia. Prazosin, minipress. Prazosin, minipress, is a vasodilator and lowers blood pressure by decreasing peripheral resistance in the arterial and venous circulation. It does not affect potassium levels. Spironolactone, aldactone. Spironolactone, aldactone, is an aldosterone antagonist. Potassium-sparing diuretics can cause hyperkalemia, especially in patients with diabetes. Furosemide, Lasix. Furosemide, Lasix, is a loop diuretic and carries a higher risk of excessive diuresis and hypokalemia than thiazide diuretics. Machine mnemonic for hyperkalemia causes. Medications. ACE inhibitors, NSAIDs. Acidosis. Metabolic and respiratory. Cellular destruction. Burns, trauma, hemolysis. Hypoaldosteronism. Addison's disease, type 4 renal tubular acidosis, RTA. Intake. Excessive. Nephrons. Renal failure. Excretion. Impaired. Management of hyperkalemia. Management depends on the severity of potassium levels and ECG abnormalities. If no ECG abnormalities are present, focus on identifying and treating the underlying cause. If ECG abnormalities are present, refer the patient to the emergency department for treatment, which may include IV calcium gluconate, antagonizes cardiac effects. Insulin and dextrose, shifts potassium intracellularly. Nebulization with albuterol, shifts potassium intracellularly. IV bicarbonate, shifts potassium intracellularly. Polystyrene sulfonate, K-oxalate, promoting excretion of potassium.